Welcome back to Care Beyond Code, the show from VBA, where we highlight the strategies and stories of those injecting a little humanity back into the healthcare admin system, making the experience better for everyone. And today, my guest is Darci Roskelley, the Director of Operations at Direct Care Administrators. Darci, thank you so much for joining me.
Thanks for having me. Hi, Adam.
On this show, we catalog all sorts of stories, conditions minor and major, timelines long and short. And in this case, we have a story which was of the utmost importance to the patient, something which was on a very tight timeline with basically no room for error. But I don't want to give too much away. Can you help to start with the context of this story? Where does this story start?
Well, this started with a member getting, very upsetting news, a diagnosis of cancer, and it ended up being a very rapid cancer. It was moving quickly. They didn't want to wait for all of, it usually takes a month or two before they start processes, and they wanted to get that started sooner, like within the next week. That's how urgent it was. And a member was given information, or the patient, from their provider stating that this course of treatment that they were going to be doing wasn't going to be covered by their insurance. And so,
why would that be the case? Just so that I'm aware, is it because of the speed at which it had to happen? Is it because of the progression of it? What sort of factors would lead to a first step being, no, this isn't covered?
Yeah, I think what started is it requires specialty drugs. And, specialty drugs is a big thing in the industry. It's really expensive, and a lot of plans aren't covering them. And the provider assumed this was through the PBM, which is the pharmacy benefit, not through their insurance. And this is through the medical part of their health insurance, not the pharmacy part. This wasn't something they were going to self-inject. This is something done in the office. So it falls under the medical benefit, not the pharmacy benefit. And I think that's where the confusion happened, is that the provider assumed it was going to be through the pharmacy and that it wouldn't be covered when that was
I see. Okay. So this starts with a little bit of miscommunication from the start, which already clouds an already urgent situation, which is the assumption that this would be under one line of care as opposed to another. Whoever's on that side sort of reads down and be like, oh, nope, experimental. This is a denial. We just ship that off and good luck to you. Well, that couldn't have inspired much hope in the patient. How did this information or story even get to you? Was it a sort of double check? Did the member come to you? How did this come across your desk?
Well, the member was calling our customer service, but they also were reaching out to their HR, their benefit manager, saying, explaining. And this company they take very good care of their members and their employees and are generous with their benefits. And so when it was brought to her, she reached out to our account manager. What's going on? He's saying it's not covered. What do we need to do to make sure this is covered? And so from there is where we had to start researching where did he get that information, because we didn't have a call to us concerning it. And so did some digging and contacting the PBM and reaching out to the physician, and just ended up being, us digging in to find out who we can talk to and where it needs, did this need to be a plan exception, or is this actually covered by the plan? Is it medically necessary? Did they get through, just all the steps that it takes when
you get a situation like that. Now, is there a defined list of steps that you go through when somebody has that sort of second inquiry into you, or like an "are you sure" checklist? Because it sounds like at the end of the day, like, oh, okay, it was just misclassified as it was supposed to be medical, and they said it was pharmacy, and that's where it ended up. But what do those first early steps look like? Like for somebody who has never seen the other side of this equation, who may have just been told, hey, you're not getting covered for this, and they say, well, what the heck, why? Let me go back to my, my rep or whoever it is. What are the various checks that you have to do to make sure, oh, okay, no, this denial was correct, I guess in this case, or to discover, oh no, actually something is amiss?
Yeah, I think a lot of it is asking more questions and understanding where the treatment is. Because when he called the customer service, he still was thinking it was pharmacy also. So, the steps so our customer service had to really dig and ask more questions on what is it that you're having done. And he didn't know a lot. He wasn't the doctor. And so then it took, them saying, where else? Where can we go to now? What are our, who can we reach out to? And so first we reached out to the PBM to see, were you contacted? Did you give some information that, and finding out where the information came from, going from there, getting doctors' names, the provider's information, or asking the member, have your provider call us, giving our account manager's phone number directly so that they didn't have to go through customer service and go through the wait. They could get through to somebody. And then us connecting them with the utilization management, so with pre-auth to make sure that. But when it all came down is finding out that there were prescriptions that were going to be needed also that were high dollar. And so we found that and got our PBM involved to outsource that so that it could be covered under the plan also and save the member number. So it wasn't just the medical treatment. But as far as the member knew, it was just my cancer treatment's not covered.
Right, of course, and that's all that you can think. You're in a one lane, mind there. So, okay, and so it turns out that there was a course of treatment required that was both considered pharmacy, I guess, and both considered medical. Now, you still have to figure all of this out. So once you intake all of this information and you say, okay, so part of it was denied, but maybe part of it should be classified as medical, maybe all of it shouldn't. But oh yes, there is also this pharmacy. Whew, now I got two tracks that you're of course responsible for coordinating and figure out. Where does it go from there? Like, where does it come back to the member? What is the inner workings there so that you make sure that the maximum, I suppose, is provided?
Yeah. Well, what we wanted was to take the member out of this equation part because it was too confusing for them. And so we wanted to be able to handle it between us as the TPA, the plan, and the pharmacy and the doctor. So, taking us, I'll handle it. And then we got back to the member and explained, you're okay. You've got you scheduled. This is what you're going to do. We can, we're going to fill this prescription for something else. It wasn't the main treatment, but we can fill this and then we're going to outsource it so that you can get it for a lower coinsurance for yourself and a lower cost to the plan. So it was just, not wanting them to be in the middle of it because it was creating way too much confusion for the member.
Now, for somebody also who hasn't gone through the process of having something outsourced, what exactly do you mean by that? Just outside of your plan, outside of a place where it's offered? What source are you going out from?
Well, instead of just going to your local pharmacy to get something, the PBMs offer different programs, and there's even through the government also, programs that are offered through the manufacturers that are a savings to the members. If they just go to the pharmacy and fill their prescription, nobody knows. They don't apply for these savings. They don't get these savings. And so
I see.
that's where us reaching out and finding out what kind of programs are there? What can we offer this member? What are the different options rather than him going to the pharmacy?
Right.
And so that's where there's international sourcing, or sometimes there's different vendors that offer like infusion, the drugs for infusion at a lower rate and things like that. So it's just outside of your standard benefits
I see.
and
Okay.
just to your doctor.
I got it. So if you have a run of the mill prescription, you might not even consider this sort of thing because it's so ordinary. But in this particular high stakes, I'm guessing high cost scenario, that could be the difference between being able to do it and not being able to do it, or something else. The international thing is interesting. I haven't quite, my understanding of the healthcare system in the US is already like, I'm trying to wrap my brain completely around it, as I'm sure a lot of people are. Going internationally from there is something that is completely outside of my understanding, but luckily is within the scope of care beyond code. So in this case, is that somewhere that you ended up going? Like, did it end up going all the way outside the US system to be able to find the right solution here?
Yeah, it did for his individual prescriptions, not for his care in the office. That we got all straightened out and covered. It was the pharmacy part that we ended up out using international sourcing to be able to, because the cost is just significantly less for certain medications.
Sure. And how
Not
common
all.
is that where that ends up being something that you even look into? Because I haven't heard of it a lot. I haven't really been in a position where I've needed something like that, but I'm sure that it exists. And of course, through this story, you're proving it. Is that common?
It is becoming more common, which is where there's also becoming more regulations. And for a little bit, there was a freeze on, being able to do it and making sure that the pharmacy and the vendor are all following the federal guidelines, just making sure that we're within everything and not going outside where we're not supposed to. And that's why there's certain drugs that are okay for you to get that way. and they're from, you know, valid pharmacies. They're not, they're
Of
not like
course.
going down and getting off-label stuff. They are
Right.
actual, like, it just the cost is so much different. And I wish that we as a country could get it turned around to where that cost and savings is to us. But right now, we're having to do this to get those savings for our members and for our plans.
Well, I'm glad that this particular member had you at the wheel to figure this out. I mean, my gosh, outside of the condition itself, like now we're 2 or 3 layers deep into the problem where the member is over here completely worried about something different, and the fact that you're able to go through and check all of these boxes while remaining compliant, while remaining on the good side of everything is great. So ultimately, then the pharmacy side is figured out. You're able to outsource some of that. The medical side you're able to do in facilities here and get the proper coverage. That sounds like a good story. What ends up happening? Like what? So let's bring the member back into the picture here. What do they see? They get a call from you or somebody presumably saying like everything's good. Here's what to do. How does that come back to the member?
It actually ended up being their human resource wanted to talk to them, their benefit manager let them know all the details, but it was our account manager that let the plan know exactly what was happening and that it's all good. He's scheduled to go on this date. He doesn't have to come up with upfront costs because they were going to make him pay an obscene amount of money up front to start. He doesn't have to do that anymore. And so when she relayed that, came back to us as, he wanted to make sure to tell us thank you for doing that and that, he's so much weight off of his shoulders and him and his wife are feeling so much better now that they don't have to worry about that part. And it's just, I mean, it's not just, the claim, it's just that person. It is more that we were worried about is him and having the added stress to his life. And
Of
I
course.
think that's where it came back is that he felt grateful that he didn't have to do that anymore. And that's where we want to be a standard of doing that and not just be for a big case, but for somebody who needs to find, a mental health provider in their area that they're having a hard time. So going out and just taking the extra steps on our part as customer service to help them.
Well, it's, I'm sure, a relief for the member to have that conversation, which is a collective exhale with their HR rep, already a conversation that most of the time you don't want to be having, but especially when it comes to this, something that has a good ending is good for everybody. I also noticed you using the present tense along the way there. So I'm guessing this is a continued course of treatment or perhaps something which is a present, and that also implies a good prognosis for that person. I'm sure centrally because you were able to get them the care that they needed. Now, you mentioned standards and how this type of behavior practice methodology can be applied to cases beyond just the high stakes, high cost, high urgency. So, is there anything about this story in particular, or stories like this one, that you've over time been able to embed into the practices of direct care, which have allowed for that consistency of care beyond whatever the code was in this case, just a high level no getting turned into a yes and?
Yeah, I think is just making sure that we're looking at the full picture. We try and relay that out to, all of our employees is don't just look at that one thing. Look at the whole picture of what he's having, what the patient or anybody, what the member needs. It might not just be this one visit. It might not just be this one prescription. And looking at that all and then reaching out to it's nice that we have the PBM, the people at the PBM that are so great to work with our vendor, for utilization management, being able to get pre-auths and having that contact between everybody and our employees knowing that they can reach out to those people for assistance in that and to work better together instead of it just being us against everybody.
Well, yeah, and I'm sure that's kind of how the patient felt at the beginning as well. The member saying, "Oh gosh,
Yeah.
it's me against the world. How am I going to proceed?" To then, of course, the end of the story, which is now I know how to proceed, or the path is being paved for me, which is one less thing to have to worry about at that time, thanks to you. And learning the whole picture, of course, is important. Well, I appreciate getting to learn this short but happy story about somebody who was faced with something daunting and possibly still is, but who had to worry about less thanks to you going above and beyond. So, Darci, for Direct Care and for all the members benefited by you all, thank you very much for coming on Care Beyond Code, sharing that story and being with us.
Well, thank you for having me, Adam. It was nice to share it and to be able to talk about ways that we can improve things.
And for you, the viewer, you've seen a bunch of stories like this: high stakes, low stakes, short timeline, long timeline. And I'm sure you could very quickly get into the shoes of the patient who might be looking up that mountain of miscommunication or misinformation, or downright misery. Well, VBA is what we do all the time, is try to create frameworks behind the scenes to help with that sort of administration so that you don't ever have to worry about something like that. VBAsoftware.com, so go check it out. But other than that, you can stay tuned here for more stories of care beyond code.